Okay, thank you very much for that introduction, and thank you to the organisers for inviting me to speak to this very important forum. I work at the National Maternity Hospital. We're one of the biggest hospitals, along with the Coombe and the Rotunda, that exist in Europe, and indeed Cork, delivering over about 8,000 or 9,000 babies per year. As a result of the volume that we see, we would see in the region of 350 pregnancies where there is an abnormality diagnosed during the pregnancy. Some of these are from our own population, and many of these are a referral from smaller hospitals, and the Rotunda and the Coombe would also see many of the abnormalities that are referred from the smaller hospitals around the country. So my brief is really to give you a factual description of what happens on the ground on an everyday basis in terms of what happens in diagnosis and where we go from there. I suppose it's relevant to start with the incidence of congenital abnormalities, which is largely accepted to be in the region of 2 to 3%. So 2 to 3 out of every 100 babies will be born with some form of abnormality. In 50%, this would be minor. It could be a skin tag or a birthmark and of no relevance whatsoever, and is very treatable. But in about 50%, these would be considered major. And a loose definition of major congenital abnormality might be that of an abnormality that will result in death or severe disability, be it major, be it mental or physical handicap, or babies who require major surgery after birth. So how do we diagnose these abnormalities? Well, there are three main modalities. Ultrasound, which virtually every pregnant mother will undergo at some stage in the pregnancy. Invasive procedures, a minority of mothers will undergo these procedures. And in the last few years, something called non-invasive testing, and I'll go on to discuss these in a bit more detail. So as I mentioned, virtually every mother in Ireland will have some form of ultrasound in the pregnancy, and there are various indications for performing ultrasound. But in line with best international practice, most hospitals offer what's called an anatomy scan at 18 to about 22 weeks to look at the baby's anatomy and hopefully provide reassurance for the mother and indeed for the father. There is an inequity in Ireland in that not all mothers are able to avail of this. It's not available in all units, and hopefully the upcoming maternity strategy will focus on making things a little bit more equitable. There are various reasons for it. There is a shortage of midwife sonographers, and I won't go on about that because that's not the remit of today. The diagnostic ability of ultrasound depends on many different factors. It obviously depends on the operator, the person who's actually performing the ultrasound. It also depends on the machinery that is being used, and as you can imagine, a machine that is state-of-the-art, high technology, brand new, is going to perform a lot better than an ultrasound that might be 7 or 8 years old, that doesn't have all the bells and whistles that a new modern machine might have. The size of the mother is very important. You all know that we're in the midst of an obesity epidemic, and I think it's important to say we do not diagnose abnormalities as well when the mother is of a large BMI. The position of the fetus is important. Some babies do not allow themselves to be seen just for whatever reason. They adopt a position of the uterus where it is difficult to see. And the gestation at when you do the scan is also important. But to summarise, most units will do a scan between about 18 and 20 weeks, and it's at that time that many people will be given reassurance, the majority, but for a minority they will have perhaps the news they did not expect. The invasive procedures are carried out much less often. We would carry out about 150 to 180 of these procedures. And they are two sort of invasive. By invasive, I mean a needle actually goes through the maternal abdomen. In the case of amniocentesis, from about 15 weeks on. A needle, as you can see, is placed into the fluid. Let me get my arrow here. Is placed in. This would be done under ultrasound guidance, so as you know that your needle is not going too near to the baby. And in the amniotic fluid, there are cells that the baby has shed from its skin or from the bladder. And thus, by aspirating up the fluid into the syringe, you then have some cells to work with in the laboratory. that can give you much more information than the ultrasound, particularly that of chromosome problems and other genetic problems. This is a similar invasive procedure, except in this case you're doing what's called a CVS, which would be chorionic villus sampling. And in this situation, you're actually taking a sample of the placenta, which shares the same genetic makeup as the fetus does. And this can be done either through the mother's abdomen or in a similar manner to a mum having a cervical smear. A sample can be obtained through the neck of the womb, and this would give you some genetic material in which the laboratory can then rule out a chromosome problem or, in some situations, other genetic problems. This is a technology that has recently come on board, and it's changing the face of prenatal diagnosis literally around the world. It's newish. It's been available in Ireland probably for about 3 or 4 years. Been available in other countries maybe a little bit longer. And it involves a simple blood test from the mother's arm. We know and have known for a long period of time, sorry, I'll just get this error, that the placenta leaks out a few threads of the baby's DNA into the maternal circulation, into the mother's circulation. In the maternal circulation, as you can see here in the blood vessel, there's maternal DNA and there is fetal DNA. And for years, we couldn't really discriminate between the two. And then that breakthrough came whereby you could separate out the fetal DNA from the maternal DNA. So now by simply doing a blood test from the mother, you can take out the fetal DNA, and by doing quite sophisticated testing in the laboratory, you can tell with virtual 99% accuracy whether a baby has Down syndrome, whether a baby has Edwards syndrome, whether a baby has Pato syndrome, all syndromes I'm sure you probably have heard or will hear about, and indeed other chromosome problems. The impact of this type of testing in other countries has been huge. In Iceland, no babies have been born with Down syndrome in the last 4 or 5 years. There is a state-sponsored, funded system where all mothers are offered this test, and all mothers are availing of the test, and all mothers, when they're diagnosed with this problem, are availing of a termination of pregnancy. And in Denmark, over the past 3 or 4 years, there have only been a handful of babies with Down syndrome born. In this country, this is not paid for by the state. I understand that the UK are about to roll this out to be available on the NHS. So this is the way the rest of the world is going. In this country, it's an opt-in service that is available all around the country. And it can also tell the gender with virtually 100% accuracy. So you might ask the question, should we be offering these tests? Well, we need to look at our medical council guidelines to see and guide us. And we've had some guidance from previous referendum. But patients have the right to be offered all diagnostic and treatment options, one of the guidelines from the Medical Council. But I think before you give or perform these tests, you must give patients enough information in a way that they can understand to enable them to exercise their right to make informed decisions of their care. And that's very clearly written as a guideline to guide us in our everyday practice. And then when it comes to talk about termination, I think the amendment in 1995 gave us some clarity. When I was starting in this area over 20 years ago, we were unclear as to whether we could even discuss termination of pregnancy. There was a kind of a very grey area. However, I think the amendment in 1995, or the Act in 1995, gave reasonably clear advice that it was lawful to give information on abortion. It is illegal or against the law to promote or advocate termination, and that is the situation that we practice in. So I'm going to give you just a few examples. This is an example of Anencephaly, a condition you probably have heard of, a 26-year-old in her first pregnancy, fit and well and healthy. She comes along for her anatomy scan that I've spoken about at 21 weeks, and she has a diagnosis of Anencephaly. This is a condition where 75% of these babies will survive the whole way through to birth, but virtually all die within hours or within days. In medicine, there's never 100%, there's never a never, and there's never an always. And there'll always be a few cases that will survive a little bit longer. We know of babies with anencephaly who have survived a bit longer. But in the main, these babies die in the very early part of life. I'm going to put up a slide of anencephaly, and I apologize in advance if it offends anyone, but I think it's important for two reasons. I think it's important because it'll be an example that will be used in this forthcoming debate of what might be termed a lethal, a fatal abnormality. But I think the other thing is that when we give a diagnosis to a couple, the first port of call is often the internet. And you can pull these sort of images up very readily on the internet. And this is what anencephaly looks like. The baby is completely normal, apart from at the top of the baby's brain, there is an absence of the brain. And that will result in the baby dying in a short period of time. So when we fall upon or when we come across a patient who has an abnormality by way of nearly always ultrasound, who actually gives the information? Well, most frequently, the first person to suggest that there's a problem or sometimes to diagnose the problem is the people who are doing most of the ultrasound around the country. And that's usually a midwife ultrasonographer who has the appropriate skills, or sometimes, in a minority of cases, a radiographer. They may well know the diagnosis themselves, but they will refer to a fetal medicine specialist, and these specialists exist in all of the major hospitals in Dublin, in Cork and Galway and Limerick, and in some of the smaller hospitals they would have someone who has had the relevant training. Or they may be referred to a consultant obstetrician who has an interest in this area. We will also involve our own very highly specialised midwives who have expertise in prenatal diagnosis. And then, depending on the diagnosis along the line, we will involve geneticists and obviously the paediatricians. So what do we say to them when we come across this abnormality? Well, obviously it's our duty as a doctor to fully explain the diagnosis. If we can tell the diagnosis, and it's not always 100%, we then have to give them an idea of what the prognosis is. What does this diagnosis of anencephaly or Edwards syndrome, whatever, what does that mean? And give them our best indication of what lies ahead. Thankfully, most of the abnormalities we see will be, or many of the abnormalities we see will be not life-limiting or fatal or lethal, and we do not need to have any further discussion about the options. But in many cases where there is a risk of serious disability or death, it is incumbent on us to discuss what the options are. And we would do this in a very non-directive way. And obviously you inform the GP at an early stage, because often the patient will go straight to the GP having seen us. It's surprising how many people are still unaware of the law. And we've come across this time and time again. When you make a diagnosis of a very serious abnormality, there is an assumption that you can continue to look after this couple in very difficult times. And they can be quite upset and sometimes quite angry when we say that is not the case. In terms of where we give this information, we give it often in the ultrasound room where the ultrasound has been performed. Some units, we're fortunate enough to have a nice, quiet, non-clinical room where we can bring our couples and have a chat. Obviously involve the partner. Most patients will attend this particular scan with their partner, but not always, and it's important to get them in as quickly as possible. We use clear, simple, easy to understand English as best we can. Access to telephone is not usually a problem because most patients have a mobile. And having given them the diagnosis and perhaps the prognosis, we give them time on their own for maybe 20 minutes, half an hour or an hour, and then we go back and see them because obviously they will have many questions. And then we offer to see them again in 24 or 48 hours. I want to just present another sort of case which is not an uncommon scenario. Here's a 41-year-old. This is an actual case. She was in her third pregnancy. She has one baby with Down syndrome. She's concerned because she's 41, and she's also had a baby with a chromosomal abnormality. So she avails of this new test, this NIPT, non-invasive prenatal testing. And that shows that she has a 99% chance that the baby has Edwards syndrome. Because NIPT is still a screening test, you'd still need to have the diagnostic test, which is the needle test I spoke about earlier on, amniocentesis. She undergoes that test, and this baby has Edwards syndrome. What is Edwards syndrome? Well, it's something similar to Down syndrome in that these babies have an extra chromosome. Everyone in this room will hopefully have 46 chromosomes, and if you have an extra chromosome, or perhaps you're missing a chromosome, it will confer different degrees of disability, possibly physical and mental. With Edwards syndrome, these are usually of a severe nature, and depending on what study you will read, most of these babies, the vast majority, will die within 5 or at 5 days, and some studies say about 14 days. So the vast majority have died in the first few weeks of life. However, 20% will live until they're 3 months. And at the end of 1 year, 90% have died, but still 8% survive, and probably less than 1% will live till the age of 10. We've heard already about the use of the words fatal and lethal and life-limiting. We tend not to use fatal or lethal in our everyday practice. When we talk to patients and we give them the diagnosis, we tell them that this is a condition which we think will result in your baby having a short life, or words similar to that. We do not tend to use the word fatal or lethal. I don't know what fatal is. Is it minutes? Is it a condition that, is it fatal if the baby dies by a certain time? And I don't think any of us know that. Ultrasound looks at the anatomy and not the function. I think it's important to just point out when we talk about ultrasound that ultrasound is not perfect and it has limitations. And we have certain situations where with ultrasound we can see a very abnormal brain. It looks abnormal. We think this baby will have severe disability. But in fact, ultrasound, which at the end of the day is fuzzy black, white and grey image, does not predict function. And I think we have to be honest as clinicians that, ultrasound has its limitations. We have certainly predicted cases to be worse than they turn out to be, and we've predicted cases to be of a reasonably good outcome that turn out to be much worse than we think. Having said that, I think with regard to prediction of severe disability and life-limiting conditions, I think we can be fairly sure in the vast majority of cases, but certainly not always. So if we go back to this lady with Edwards syndrome, what are her options? And we would discuss this freely. She can continue the pregnancy, or she can decide not to continue the pregnancy. And we will support her in whatever route she decides to go. The vast majority of patients will continue the pregnancy, and if they decide to continue the pregnancy, they are taken away from the busy humdrum of an antenatal clinic where there may be 70 or 80 patients. They are seen by an individual consultant on a one-to-one basis for continuity of care. They'll be given time. They'll be given specialised midwifery care. They will meet with the neonatologist, and you'll hear more from Adrienne, or they might meet with the relevant specialist. So if the baby has a heart abnormality, they will meet with the heart specialist from Crumlin who comes over to our hospital. Or if the baby has spina bifida, they will meet with the neurosurgeon who will come from Temple Street to discuss their individual case and the management thereafter. We have weekly multidisciplinary meetings where it's not just my opinion or one of my colleagues' opinion. We all sit round together to discuss the best and optimal management of these patients with regard to the pregnancy, the labour, the delivery, and indeed the early newborn period. All of these patients are given a card where they have a direct line to a midwife specialist. They don't have to go through the busy hospital switchboard. And we involve social work, chaplaincy, bereavement services, counselling services where appropriate. It's a little bit upsetting sometimes to hear from some areas in the media that we do not provide perinatal hospice care. This is perinatal hospice care, and it is provided and has been provided for many years. And we do our level best to try and ensure that a woman, or indeed a couple, will get the best of care throughout the pregnancy if they decide to continue the pregnancy. They will get individualised care, and we will try and make that life that may be short as precious as possible. That's not the route for everyone, and there are those who will decide that this is not for me. And in my experience, there's probably a small percentage of patients who have thought this through, who have no qualms. They've talked about the testing. They know what they're going to do. They have no qualms about traveling over for a termination of pregnancy. They don't get too emotionally upset about it, and they move on to their next pregnancy. They're probably a small percentage. At the other end of the spectrum, there are those people who get quite upset with even the words prenatal diagnosis, and certainly the word non-continuing the pregnancy or termination of pregnancy. I think the vast majority of people fall somewhere in between, and many of our patients will say, I'm completely against termination, I'm completely against abortion, but you know what? This is me, and this is my pregnancy, and this is my family. I never thought I'd be in this position, but I'm going to have to go away and think about it. And they spend sometimes hours, days, weeks agonizing over this decision, and they make the decision that they feel is best for them. When they've made that decision, our role is to give them the phone number to the relevant UK units. We're not allowed, as we said earlier on, refer patients for termination of pregnancy. So the patient makes the phone call. We're allowed by law to provide all the relevant information, but the arrangements are made by the patient. And they obviously bear the cost of the flights, the accommodation, and the medical procedures. One of the problems of patients travelling, depending on the type of termination, depending on the unit that they go to, is that we don't always have a post-mortem available. And that can be important for counselling for a future pregnancy. Will this happen again, doctor? Sometimes we're saying we don't know because we don't have that relevant information. And we would always go to great lengths to try and arrange postnatal follow-up for these patients. We also have to discuss with them, if they choose this route, what termination of pregnancy involves. And I suppose they could be subdivided into early termination of pregnancy and late termination. Early is where one might be given a prescription for tablets which cause contractions and expel the baby from the womb. The other method that would be commonly used is surgical, and this is a little bit like a D&C. What is a D&C? Well, D stands for dilate, so the neck of the womb is opened up, and C stands for curettage, which is essentially spooning out or removing what is in the womb. And we have to tell the patients, depending on the stage of pregnancy they're at, what lies ahead. Many of our patients, because as I've said, are diagnosed late, and therefore they will undergo a late termination of pregnancy. And this can be surgical, as in they go asleep, they have an anaesthetic, they undergo this D&C procedure, but the baby will not be removed intact. And I think on the way in here today, you will see pictures of what a baby will look like with such a procedure. If they're very late in gestation, the physicians looking after the pregnancy will actually perform a procedure where resulting in the heartbeat stopping. This is to prevent the baby from being born alive, where the obligation might change, and they would be their labour would then be induced and they would deliver a stillborn baby. And that's obviously a very difficult journey for any patient to undergo. So what are the facts? What is actually happening on the ground for Irish women when they find themselves in this situation? These aren't my figures, they're not Holles Street figures, but they're UK figures for Irish women in 2015. And you can look at it on the UK government website. There's a very comprehensive annual report of all abortions carried out in England and Wales. And by way of comparison, there are 185,000 terminations carried out in the UK. That's 500 terminations every single day in the UK, vast majority of these being less than 13 weeks. 3,451 who give their address as being in Ireland, and I think we have to assume that there are those who may have friends or relatives who may give an address, so this is probably a slight underestimate, will undergo termination of pregnancy in the UK. Of those 3,500, about 4% will have a termination under what's called Section E of the 1967 Abortion Act. And that is, they qualify for an abortion or a termination of pregnancy because their baby is deemed to have a serious risk of a physical or mental handicap or death. So 135 of these have been classified 4%. Now, this figure is not quite accurate, 112. 112 Irish women in total. That 112 should be out of the total of 3,500 undergo late terminations. But I think it's reasonable to assume that many of the patients, many of these patients who go over are actually having later terminations of the 135. Now, why are they going over to have terminations of pregnancy? Well, again, they give a fairly comprehensive breakdown on the Irish figures. 69 of them go over because of chromosome problems. And the biggest group by far is Down syndrome. 40 with Down syndrome. I don't think anyone here would say that this is a fatal, lethal, life-limiting condition. Though Down syndrome babies now will live till 50 or 60, they may not live as long as the normal lifespan of maybe into the 80s now. But 40 of these are for Down syndrome. If you think of the figures I said to you earlier on about Iceland and Greenland, we would expect to have about 100 babies a year born with Down syndrome in Ireland. Now, not all babies with Down syndrome in the womb will survive the pregnancy. It's reasonable to assume a third will probably die in the womb. But you're left perhaps with 30 babies with Down syndrome who could have been born in Ireland, who are not being born in Ireland. We're not Iceland and we're not Denmark, but there's a trend there. 13 with Edwards syndrome that I pointed out to you, 7 with Pata syndrome, which is also seen to be a very serious chromosome problem, and 9 others. And then there are sort of anatomical conditions where patients choose, having been given the information, to make that difficult journey. And there were 66 of these, 23 involving the brain or spine, 7 of which were Anencephaly. 9 were cases of spina bifida. And then there's a range of different abnormalities, 10 heart abnormalities. We don't have the details, but we can only assume that these are very serious congenital heart abnormalities where there may have been a short life or may have involved major intensive surgery for long periods of time with poor outcomes. Kidney and bladder problems, 4, musculoskeletal, 13, and a host of other conditions. So what is the future? Well, I think in Ireland we'll have better access. Hopefully in the not too distant future, all of our women can avail of the services that should be available. I think as the operators get better and the technology gets better, there will be more and more ultrasound diagnosis of abnormalities, and that's just the reality. With regard to this non-invasive prenatal testing, you know, the scientists will say that this is revolutionary, it is exciting, but the effect of non-invasive prenatal testing needs some reflection because of its effects on society. But we will see, and we're seeing year on year, an increase in the uptake of this non-invasive prenatal testing. That will result in an increased number of chromosomal abnormalities being diagnosed. We will also see, as the research has already showing, that it won't be just confined to 2 or 3 or 4 chromosome problems, but that it will be possible in the future to diagnose more and more abnormalities by a simple blood test from the mother. So to conclude, prenatal diagnosis is widely available in Ireland, widely practiced. The number of prenatal diagnosis cases are increasing, especially this NIPT. We do discuss the options in a very hopefully sensitive. I think we could always improve, but I think we go to great efforts to non-directively counsel. Many continue, the majority continue the pregnancies, but 135 in the year 2015 chose not to. Thank you very much.